Hey future doctors, welcome to Dentistionary. We are back with the second part of the bone, and in this part we will be discussing some important stuff. So let's start. First of all, the bone remodeling. It has four phases. The quiescent phase, it has two parts, the rest one and the ongoing one. The activation phase, resorption phase, and the mineralization phase, or we can say it reversal phase. Okay, so what's bone remodeling? It is a continuous physiological process that happens in the adult skin, and in this, bone resorption is followed by the new bone formation. So it inhibits the bone resorption, and maintains it mechanical strength and structure. So it is performed by clusters of bone resorbing osteoclast and bone forming osteoblast arranged within temporary anatomical structures known as the basic multicellular units, BMUs. Okay, and there are so much things you should know about, and these rankle and rank things you can study those full forms in your Orban's book. They have written it. Then these active BMU consist of a leading front bone resorpting osteoclast that forms the cutting cone, and the reversal cells of unclear phenotype follow the osteoclast, covering the newly exposed bone surface and prepare it for deposition of replacement of bone. So it means that bone remodeling happens after the bone resorption. Okay, our bone get already remodeled after the resorption. The resorption occurs and the remodeling occurs. So we does not see any difference in them. But after the age change, the rate of the remodeling is low. So we see the resorption. So this balance which is created in that is called the coupling of bone resorption and formation. It has sequences which we will talk about. The quiescent phase at the rest. In this, the bone turnover rates of 30% to 100% per year are common in rapidly growing children. In adulthood, the rate is slow. The turnover rate of trabecular bone and endosteal surface of cortical bone is more than cortical bone turnover. So the sequence of events are like this. Quiescent phase is at rest, there nothing happens. In the activation stage, the cells of the osteoblast lineage interact with the hemopoietic cells, and this initiates the osteoclast formation. This stage of bone remodeling involves detection of an initiating remodeling signal, and this signal can be as a result of mechanical strain causing structural damage or a hormonal effect on the bone. And the daily activity also places mechanical strain on the skeleton and the osteocytes, so it probably sends changes in the physical forces and translate them into the biological signals that initiate the bone remodeling. So see, the detection of signal in the form of mechanical strain or hormonal action by osteocytes, then these signals translate into the biological signals, then the recruitment of monocyte macrophage osteoclast precursors, then they interacts with the osteoclast and osteoblast precursor cells, which are rankle on osteoblast and rank on osteoclast. Then the differentiation, migration and fusion happens of large multinucleated osteoclast. Then comes the resorption phase. In this, uh, osteoblasts respond to the signals generated by osteocytes and recruit osteoclast precursors to the remodeling site. So what happens here is the osteoclast precursors are removed and the osteoblast precursors are ongoing. So recruitment of osteoclast precursors happens, then the osteoclast dissolved minerals followed by the release of TGF, PDGF, IGF-1 and 2, which scallops the house-shaped lacunae that are formed, resorption tunnels and cutting cones and all. Then the mononuclear cells or the macrophages remove the collagen remnants. The osteoclast tunnel into the surface of the bone, which lasts for 3 weeks in Harvesian canal, closest to the surface, osteoclasts travel along a vessel and it resorbs the Harvesian lamellae and a part of circumferential lamellae and form a resorption tunnel of or cutting cone. So its main purpose is to cause the cutting cones and the resorption tunnels in the bone surface. Okay, so it can get exchanged. Then the reversal stage comes, or the mineralization phase, which has the incorporation of the hydroxyapatite crystals. In this, it is followed by the reversal phase, which comprise the differentiation of osteoblast precursors and discontinuation of bone resorption with osteoblast apoptosis. So here apoptosis of the osteoclast occurs, then the bone resorption stops. It inhibits the bone resorption. Following the osteoclast mediated resorption, the house shaped lacunae remain covered with undigested demineralized collagen matrix. Then a mononuclear cell of undifferentiated undetermined lineage removes these collagen remnants and prepare the bone surface for subsequent osteoblast mediated bone formation. And in the bone formation stage, activated osteoblast lay down new bone mineral. Okay, new bone materialization होता है उसमें. Then the resorbed bone is entirely replaced by a new one. So these all happens with that. Then it acts as a cohesive mineralized layer which adhere this newly formed bone surface to the old bone, and this always happens in the cycle. There are certain hormones which mediate the bone remodeling. There are systemic factors and the local factors. Systemic factors as hormones which decrease the bone resorption, calcitonin and estrogen. Increases the bone resorption, it has PTH, parathyroid hormone, vitamin D, high doses. Then many more which increases the bone formation, that are growth hormone and vitamin D, which is physiological doses, insulin and the PTH, glucocorticoids also. Then they decrease also for bone formation. These are glucocorticoids. So you can just correlate it with the diabetes mellitus, in which the bones become weak. It's because of the glucocorticoids. Or glucocorticoids are like type of steroids and the corticosteroids. So it causes the decrease of the bone formation in high doses. Local factors have many factors: growth factors, IGF-1 and 2, BMPs, FGF, PDGF, EDF. ये सारे आपके ऑर्गन्स में फुल फॉर्म्स दिए हुए हैं. उसके बाद इसमें सबके अलग अलग काम है. क्विसेंट फेज वही नॉर्मल फेज है. इसके बाद सबसे इम्पॉर्टेंट आता है एल्वियोलर बोन. What is alveolar bone? The alveolar process is defined as the part of the maxilla and the mandible that forms and supports the sockets of the teeth. It's the part of the bone which holds your teeth in place. Okay, which have the home to the root of your teeth. The functions are: it houses the roots of the teeth, anchors the root of the teeth to the alveoli, which is achieved by the insertion of sharp fibers into the alveolar bone for proper, helps to move the teeth for better occlusion, helps to absorb and distribute occlusal forces generated during tooth contact, supplies vessels to the periodontal ligament, houses and protects developing permanent teeth while supporting primary teeth, organizes eruption of primary and permanent teeth. These are the basics. Then the structure, which consists of two parts, alveolar bone proper and the supporting alveolar bone, in which they are further divided like bundle bone and lamellar. Bundle bone carries the principal fibers, and the supporting is outer cortical plates and inner spongy bone. So the cortical plates has compact bones, and the inner spongy bone has the cancellous bone or the spongy bone. Okay. Then comes the alveolar bone proper. Let's study about it. It surrounds the tooth and gives attachment to the periodontal ligament fibers. It attaches the periodontal ligament fibers to the root of the tooth. So it consumes or distributes the masticatory forces. Then it consists of the laminated bone or lamellar bone and the bundle bone. Laminated bone or lamellar bone consists of osteons. Concentric lamellae along with the central blood vessels form an osteon. The bundle bone, it is a part of the alveolar bone where periodontal ligament fibers are inserted. Okay. Then the Sharpie fibers, these are the principal fibers of the periodontal ligament that are embedded in the bone or the cementum. And these fibers are seen perpendicular to the bundle bone. It is very much point of view from the exam point of view, it is very important. Other fibrils are less and are arranged parallel to the bundle bone surface. Radiographically is more radiodense due to the presence of thick bone without trabeculations and is called lamina dura. You can see it in the radiological graphs or IOPs and OPGs X-ray. The lamina dura is very properly prominent in that. Then the lamellar bone, it contains osteons which has blood vessels in a Harvesian canal. Blood vessel is surrounded by concentric lamella to form osteons. Some are arranged roughly parallel to the surface of the adjacent marrow, whereas others form the Harvesian canal. It has also a very important part, the cribriform plate. The alveolar bone proper, which forms the inner wall of the socket, is perforated by many openings that carries branches of the interalveolar nerves and blood vessels, which will create importance in the third year when you will study about local infiltration. Okay, and therefore it is called cribriform plate. It is perforated and is called the cribriform plate. Interdental interradicular septa have canals known as canals of Zuckerkandl and Hirschfeld. Then the supporting alveolar bone, it consists of cortical plates and the spongy bone. Cortical plates are made up of compact bone and form the outer and the inner plates of the alveolar bone. Cortical bone varies in thickness in different areas. It is thicker in the mandible than in the maxilla and thicker in premolar and molar region than in the anteriors. This is the difference. Spongy bone, it fills the area between the cortical plates and the alveolar bone proper. It contains trabeculae of bone and marrow spaces. It has types spongiosas. Type 1 spongiosa, these are the trabeculae are regular and horizontal like a ladder. So these are commonly known as ladder spongiosa. Type 2 are regularly arranged, delicate and numerous tuberculi. These all just absorbs the masticatory forces and distributes the evenly in the bone, so it doesn't get fractured. The spongy bone is very thin or absent in the anterior regions of both jaws. Then comes the alveolar crest, the crest of the alveolar septa. It meets the cortical plates at the alveolar crest. What? The alveolar bone proper. In healthy mouths, the alveolar crest is around 1.5 to 2 mm below the cementoenamel junction. Then comes the age changes. First age changes is the bone resorption, which you have studied in previous part. And then comes the brittleness due to the decreased water content. Sponge bone becomes thin trabeculae, wide marrow spaces. Red bone marrow becomes fatty. Osteoporosis. Alveolar crest slope distally due to the mesial tilting of teeth. With loss of teeth and resorption of the alveolar ridge, mantle foramen becomes very close to the ridge in the mandible. Also, maxillary sinus in the upper jaw is very close to the teeth. So sometimes in the old age people, as we extract the tooth or teeth, many teeth, so it can cause trauma because of the decreased density of the bone, weakness of the bone, or because of the mantle foramen is very near to the alveolar socket and the maxillary sinus is very near to the maxillary alveolar socket, so it can cause trauma like that. Thank you so much. I hope you found this video useful. If you want the PPT, follow the link below, and if you have any doubts and queries about this video, we will try to solve it as soon as possible. Please comment down below. Thank you so much.